Hi friends, I welcome you all for this session. In this video, we are going to continue with the abnormalities of umbilical venous system. We will just have a recap of what we have seen in the previous video. In the type 1 abnormality, which involves anatomical and morphological abnormalities of portal vein, we have seen portal vein aneurysm and portal vein variants. In the type 2 classification, about the abnormalities of umbilical vein, we have seen PRUV and also about double umbilical vein. Umbilical vein varix is nothing but the abnormal dilatation of the umbilical vein. It can be either intrahepatic or extrahepatic. The umbilical vein varix may occur due to narrowing of the umbilicus, weakness of the vessel wall, or dilatation of the vein after compression or partial loss of smooth muscle in the vessel wall. Focal dilatation of intra-abdominal subhepatic portion of the umbilical vein is termed as fetal intra-abdominal umbilical vein varix. It's a rare abnormality with a prevalence of around 0.6 per 1000 to 2.8 per 1000 deliveries. The extrahepatic portion of the umbilical vein is considered the most vulnerable segment. Therefore, conditions associated with increased umbilical venous pressure or high flow states can result in the dilatation of the vein at this location, predisposing to the formation of the umbilical vein varix. Now, coming to the evaluation of the intrahepatic portion of the umbilical vein, it can be evaluated in two standard sonographic sections. The first is the axial section at the level of the cord incision into the fetal abdomen. At this location, the umbilical vein varix typically appears as an hypoechoic or cystic or oval-shaped structure oriented obliquely in cephalocaudal direction and located between the anterior abdominal wall and the inferior margin of the liver. This is the varix of intra-abdominal extrahepatic portion of the umbilical vein. On color Doppler, it will show venous flow. Second important plane for examination is the sagittal section centered on the umbilical opening, as you can see in the ultrasound picture on the extreme right. This sagittal section is important for clear visualization of the continuity of dilated segment with umbilicoportal venous axis. There are three definitions available to describe umbilical vein varix. That is, the umbilical vein diameter of greater than 9 mm irrespective of the gestation age, a diameter more than 2 standard deviation above the mean for corresponding gestation age, a focal dilatation measuring at least 1.5 times the diameter of adjacent non-dilated segment of the umbilical vein. Any one of these criteria is sufficient to make the diagnosis. Now, how to measure this varix diameter? It is to be measured from one outer edge to the opposite inner edge with electronic calipers on the axial images immediately coupled to the insertion of the umbilical vein into the fetal abdomen. Earlier studies have reported a strong association between this intra-abdominal umbilical vein varix and major structural malformation along with poor perinatal outcomes. However, more recent systematic review and large retrospective studies have demonstrated a substantially lower incidence of associated major structural anomalies ranging from 9 to 28% and a low prevalence of chromosomal abnormality with a rate of around 0 to 5%. Normally, the umbilical vein diameter increases linearly with gestation age from approximately 2 mm at 15 weeks to about 8 mm towards the term. The study by Mahoney and Wang has provided us the reference curves based on the measurement of the intra-abdominal portion of the umbilical vein. Also, these reference curves are derived from large cohort. The reference curves by the Mahoney and Wang for umbilical vein diameter, velocity, and blood flow has been included here for your reference in need. Umbilical vein varices can be classified into three morphological types. These include diffuse dilatation of the entire course of the umbilical vein, or there can be multiple limited umbilical vein varix, or there can be aneurysmal dilatation of umbilical vein varix. Now let's see each one of them separately. Coming to the first type, as seen in these images, there is uniform dilatation of the entire course of the umbilical vein. On pulsar Doppler, the peak systolic velocity reaches up to 60 centimeters per second, which is significantly higher than the normal umbilical vein velocity of 10 to 15 centimeters per second. In this slide, you can see the picture of the umbilical vein where You can see more than one focal segmental dilatation with the intervening segments of normal or relatively narrow vein rather than the uniform dilatation that we saw already. So this type is known as multiple limited umbilical vein varix. In this slide, we are going to see about the aneurysmal dilatation of the umbilical vein varix, where there is a localized and sac-like aneurysmal dilatation of the umbilical vein, while the proximal and distal segments of the vein are relatively normal. Grayscale, it appears as a rounded or sacular cystic structure along the course of the umbilical vein. The Doppler shows turbulent high velocity and irregular flow within the sac, and making this to be a most hemodynamically unstable form of the umbilical vein varix because of the large size, which can predispose to turbulence and also thrombus formation easily. As described already, when a cystic mass is identified along the course of the umbilical vein, the next step is to apply color Doppler to confirm its vascular nature, followed by the pulse wave Doppler to characterize the flow. Normally, the umbilical vein shows monophasic non-pulsatile flow with a mean velocity of about 10 to 15 centimeter per second. Familiarity with this physiological normal pattern is important so that when we come across an abnormal flow pattern, we can identify it immediately. In the third trimester, mild waveform modulations may be seen due to fetal breathing movements and are considered physiological. In contrast, the triphasic or markedly pulsatile waveform is abnormal and is typically seen in severe fetal growth restriction. Whereas if you see the Doppler of umbilical vein varix, you can find that there is abnormally increased velocity, loss of flow uniformity, there is increased turbulence, and sometimes bidirectional flow resulting in irregular pulsatile high velocity venous waveform, as you can see in the images. The presence of thrombosis is one of the known complications of umbilical vein varix, hence we should actively and systematically assess for the presence of it. In grayscale imaging, the thrombus can be visualized as intraluminal echogenic structure, as you can see in the picture. Even if the thrombus cannot be identified in grayscale, the diagnosis is primarily based on color Doppler imaging, which can show either partial or incomplete filling of the vascular lumen. It is also important to remember that the risk of thrombus formation is higher in cases with marked dilatation of the umbilical vein and in presence of turbulent or disturbed flow. Several studies have reported obstetric complications associated with umbilical vein varix. They have fetal growth restriction in approximately 3 to 5% of the cases, and oligohydramnios in 2 to 3%, and intrauterine fetal demise in 5 to 7% of the cases. Once the diagnosis of umbilical vein varix is confirmed, we need to rule out the major abnormalities, including precordial vein abnormalities and also soft markers. The couple should be counseled to explain the ultrasound findings and also the obstetric complications that we may come across, as we have discussed in the previous slide. In isolated umbilical vein varix, increased antenatal surveillance is required, and the parents can be reassured that postnatal outcome is going to be usually favorable, as the umbilical vein physiologically regresses after birth. In non-isolated cases, genetic counseling should be offered, and amniocentesis or NIPT should be done to rule out the aneuploidies. Early in third trimester, serial ultrasound along with Doppler should be used for monitoring, along with the non-stress test. At each surveillance visit, the primary aim is to actively look for the evolving complications. This includes ruling out fetal growth restriction with evidence of fetal compromise, development of hydrops, and any significant increase in the size of umbilical vein varix. Now the question is, how does the size of the umbilical vein varix evolve over time? In majority of the cases, that is around 60% of the cases, the size of the varix remains either stable or increases only minimally, that is around 1 to 3 millimeter, and it is going to be parallel to the normal linear increase in the diameter of the umbilical vein with advancing gestation. So in most cases, the varix is not going to show a significant increase in size. However, in around 30% of the cases, there is more pronounced antenatal increase, typically in the range of around 4 to 9 millimeters. This change can occur at any gestation age, irrespective of when the diagnosis was first made. Only very few cases have been reported to show reduction or regression in the size of the varix during pregnancy. When the diameter exceeds 12 millimeter, it is considered as a major or significant dilatation of the umbilical vein varix. Now, as the size of the varix increases, the risk of complications also increases, including turbulence, thrombosis, and adverse fetal outcomes, highlighting the importance of serial and careful follow-up. Earlier studies have recommended and practiced an early delivery once the lung maturity is confirmed, but current recommendations practiced are to monitor the pregnancy beginning from the diagnosis of varix till the term, and where induction or cesarean delivery is done as per other obstetric indications. Early delivery is indicated when there is evidence of fetal distress or other complications like hydrops or presence of thrombosis, etc. We have seen already that extra-abdominal umbilical vein varix is relatively rare when compared to the intra-abdominal umbilical vein varix. As the varix is located extra-abdominally, there is a possibility of having more marked venous dilatation and slow flow and turbulence, because of which there is increased chance of thrombus formation when compared to the intra-abdominal varix. So all this feature increases the risk of sudden IUD in these cases. Therefore, given the high risk of acute deterioration, close monitoring is essential. Therefore, when planning for a management, several factors must be considered together, including degree of venous dilatation, presence of thrombosis or turbulence, gestation age, and fetal hemodynamic status. These parameters directly influence the clinical decision making. Thank you so much for watching. If you like this video, please subscribe and share to your friends.